Our next speaker, and I really hope I don't butcher your beautiful name, is Oana Tatucu-Babet, and Oana has a background in dietetics. She's currently completing her doctorate at La Trobe University and holds a position as a research assistant in the nutrition program at the ANZIC RC at Monash University. She has an interest in gastrointestinal dysfunction during critical illness, as well as the use of indirect calorimetry in guiding nutrition delivery. Welcome, Oana.
Thank you, and you pronounce my name beautifully. So firstly, thank you for the opportunity to present today. The topic of my presentation is the measurement of intestinal permeability in critically ill patients. An important yet often overlooked function of the GI tract is in protecting the body from the entry of harmful substances, such as bacteria and toxins, and this role is known as the intestinal barrier function, with intestinal permeability providing a measure of intestinal barrier function in the GI tract. The current non-invasive gold standard method of measuring permeability is the dual sugar test. This test assesses the ability of inert sugars to cross the mucosal lining of the GI tract via the transcellular route, which looks at movement, let me try and use this pointer, through the cell, and is assessed using monosaccharides. We also look at paracellular route, which assesses movement between the cells. And sorry, it's hard on an angle, but yes, between the cells. And it's assessed using the larger disaccharide, with increased permeability reflected by an increase in paracellular compared to transcellular permeability, which is reflected in that right-hand image where there are gaps between the cells of the gut, allowing macromolecules such as endotoxins to enter the body and ignite an inflammatory response. And this test is based on the assumption that premucosal factors such as gastric emptying and postmucosal factors such as renal function affect the excretion of mono and disaccharides equally, and that's an important underlying assumption of the test. In the 1990s, there were a number of studies measuring permeability in the ICU that suggested that small intestinal permeability is increased in this population and that it is linked with complications including sepsis and multiple organ dysfunction syndrome. However, an important study in 2002 raised concerns regarding the use of this test in the ICU as alterations in renal function were found to affect the excretion of mono and disaccharides differently, and that mannitol, quite popular sugar probe used to measure permeability, was present in red blood cell solutions as an additive. And since that study, no further studies have measured permeability with consideration to renal function or these test confounders prior to looking at permeability with clinical outcomes. And they also haven't evaluated newer and more sensitive multi-sugar tests in this population. So the aim of this study was to investigate the relationship between segmental permeability, measured using a sensitive multi-sugar test, with renal function and some potential test confounders in critically ill mechanically ventilated patients, prior to then looking at the association with clinical outcomes and comparison with healthy populations. So critically ill patients were recruited from the Alfred and Sunshine ICUs in Melbourne, Australia. We completed the measurement within 72 hours of ICU admission, and our aim was to recruit a convenient sample of 20 to 30 patients, as this method had not been previously used in the ICU, but had been validated in a healthy population. We included adult patients receiving or suitable for enteral nutrition, likely to require mechanical ventilation for greater than 24 hours, and receiving inotropes and vasopressors at the time of enrolment. And we excluded patients with conditions known to increase permeability and patients on continuous renal replacement therapy, as the measurement was dependent on urine collection. Ethics approval was granted from the respective committees, and we obtained consent using the person responsible model as patients were sedated. In order to measure permeability, we dissolved 1 gram of sucrose, 0.5 grams of L-rhamnose, 1 gram of lactulose erythritol sucralose in 50 ml of water, and administered the solution as a nasogastric flush. That marked the beginning of a 24-hour urine collection, and we analysed concentrations of sugars in urine samples using gas chromatography mass spectrometry. We were unable to measure gastroduodenal permeability as baseline concentrations of sucrose interfered with the measurement. However, we measured small intestinal permeability using the lactulose-rhamnose ratio and looked at the percentage recovery of L-rhamnose and lactulose as measures of trans and paracellular transport. And these sugars were selected as they are fermented when they reach the colon by bacteria, so they only provide information on small intestinal permeability. We measured whole gut permeability using sucralose-erythritol ratio and looked once again at the percentage recovery of each of these sugar probes individually. And these sugars were selected as they're not metabolized by gut bacteria within the GI tract. During the 24-hour urine collection, we collected the below variables to determine if there was an association using correlation analyses between IP measurements and renal function. So we looked at the estimated GFR, highest creatinine, and total urinary volume. And then, in terms of confounding variables, we looked at the lowest MAP, lowest PaO2, and lowest pH, as low oxygen delivery to the gut and a lower pH has been linked with increased permeability. And I should say that we collected these as they were routinely available as part of medical care. We recruited 21 patients in total, with approximately 60% were males, median age of 57, median BMI of 27. We had quite a mix in diagnoses, with trauma representing the main reason for admission. And our Apache 2 score mean was 19, which is fairly on par with Australia and New Zealand data, or slightly lower. We didn't find any significant associations between the percentage recovery of mono and disaccharides and IP ratios with urinary volume, lowest MAP, lowest PaO2 and lowest pH. And I haven't presented these values as there are quite a lot of different measurements there of permeability. In terms of renal function, we classified impaired renal function based on a GFR under 90 and normal renal function with a GFR equal to or above 90. We ended up with 12 patients with normal renal function and 9 patients with impaired renal function. We found a lower recovery of L-rhamnose and erythritol, which are the monosaccharides that look at transcellular permeability in patients with impaired renal function. However, this was not then reflected in the recovery of the disaccharides, so lactulose and sucralose, which were equal across the groups. And this difference in recovery of the mono and disaccharides was then reflected in a higher L to R ratio reflective of small intestinal permeability, but there were no differences in whole gut intestinal permeability. So in this study, we didn't find associations between potential urinary volume, PaO2, MAP, and pH as potential confounders of IP. However, we did find that patients with impaired renal function had decreased recoveries of mono and disaccharides. And these findings support previous results that renal impairment may affect the recovery of the mono and disaccharide probes differently in the ICU, and that alters that intestinal permeability ratio and our interpretation of whether intestinal permeability is increased. This violates one of the central underlying assumptions of the IP sugar test. And as renal function is quite common in ICU patients, we need more reliable measurement tools to measure permeability in this patient group in a research setting to see if there really are associations with sepsis and all of these clinical outcomes. And findings from previous ICU studies often don't look at renal function or other sort of confounding variables and should be interpreted with caution. Of course, one of the limitations was our small sample size, but from this study we conclude that alterations in renal function may affect the recovery of trans and paracellular permeability sugar probes differently in the ICU, and more simplistic and reliable tools that are not preferably dependent on urine collections are needed in this setting. I'd like to acknowledge the investigators on the project from Alfred Health, Western Health and La Trobe, and the funding body OSPAN for their support. Thank you.
you, Oana. Any questions from the audience? Oana, given that the sample size was quite small that you did, is this sufficient evidence for us to think we need to look for a new test, or do we need to collect more data? Where does the balance of the evidence sit?
Sure. There are other studies in animal populations that also suggest that renal function does affect the recovery of the mono and disaccharides differently. It would be good to explore on a larger cohort, but together with other measures of intestinal permeability as well. Yes. Sorry, I forgot the beginning of your question.
Well, it was really, is this a confirmational study? Is this enough?
It's not.
Does there need to be more? I mean, there obviously needs to be more work to develop a new test.
Yes.
But does this tell us?
It would be good to look at it in a larger cohort with a larger representation of different categories of renal dysfunction also. Mm-hmm. And of course, we didn't look at causation. We just used correlation analyses and independent t-tests to look at this. So yes, probably needs to be explored further. And definitely for studies measuring permeability and still using these tests, because they do exist, they should include renal function as variables that they collect. Yeah.
And is this only a research tool? Could this be implemented in any form of, 24-hour urine collections are notoriously difficult in the critical care setting.
Yeah.
Do you think there is an easier or more feasible way we could measure this in the clinical setting, given the impact of the potential outcomes?
I completely agree that 24-hour urine collections are quite laborious to complete. Some studies do measure permeability using 0 to 6 hour urine collections when they're looking at small intestinal permeability. However, because of the impaired intestinal transit in ICU patients, I don't necessarily think that time frame is enough. There are some potentially good tools coming out to measure permeability, such as measuring the urine concentration of tight junction proteins, which would just be a spot test, but they need to be validated and assessed first. Yeah.
Thank you.
Thank you. Thanks.